Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and today we are going to discuss a very common condition which you are going to see in your clinical practices and in your examinations very often. So these two pictures, they represent the extreme form of hypothyroidism. Now, once somebody develops hypothyroidism and it remains undiagnosed, which is still a possibility in our country, unfortunately, patient may develop full-fledged myxedema, and myxedema is characterized by these looks. So puffy look and very coarse hair, rough skin, macroglossia, and so I think these looks are very characteristic. Any experienced physician will have no difficulty identifying these cases. But of course, we do not want our patient to go to that stage, and it is important to diagnose these conditions early so that their lives can be made better. Now, these recommendations are based on American Association of Clinical Endocrinologists and American Thyroid Association guidelines 2012, which were not later updated because they are still valid. So, introduction to this condition. Number one, it is what is the definition? Inadequate thyroid hormone. When you have not sufficient level of thyroid hormone in the body, then you develop this condition, and it could be primary when the disease is in the thyroid gland itself, secondary or tertiary. Secondary when the disease is in the pituitary gland, and tertiary very rare situation where the problem is in the hypothalamus. You all remember hypophyseal, pituitary, and thyroid axis. Then common, it is fairly common, I believe, and once somebody develops hypothyroidism, especially if somebody develops myxedema, it is usually irreversible. That means we have to give the treatment for life, and it is a truly multi-systemic disease. By that I mean that practically every part of body, every single cell of body is affected. So you will appreciate this fact when I go through the symptoms and signs. Every possible symptom in the textbook of medicine can be the symptom of hypothyroidism. The onset is usually very subtle, but it advances to myxedema if missed. Of course, we do not want it to be missed, and we do not want it to proceed to myxedema level. And very important, it is one of the most treatable conditions. There are many diseases in our field which are not treatable. So, and we feel very helpless. But hypothyroidism is one of the most treatable conditions. Now, this is for your revision. We have already talked about this hypothalamo-hypophyseal thyroid axis, tertiary, and I mean, this is the thyroid gland. This produces T4 and T3, mostly T4, but some amount of T3. T3 is metabolically much more potent than T4, but most of the T3 present in our tissue is in the blood is converted from T4 by an enzyme called deiodinase. And thyroid is stimulated by the anterior pituitary through TSH, thyroid stimulating hormone, and this anterior pituitary is stimulated by thyrotropin releasing hormone by the hypothalamus. So one way there is a stimulation, and then there is the inhibitory effect. Hypothyroidism can occur if the thyroid gland itself is not functioning. That will be referred to as primary hypothyroidism, or when pituitary is not sending enough TSH to the thyroid gland, that would be called secondary hypothyroidism. But remember, when there is secondary hypothyroidism, there is likelihood of other hormonal problem also. Then occasionally, if the problem is in the hypothalamus, that could result in tertiary hypothyroidism. And mostly if you see a case and if you're unable to differentiate between the three, you should assume that this is primary, because in 90 to 95% of the cases of hypothyroidism, it would be a primary thyroid disease. Etiology, I think mostly it is autoimmune, and there is some selective autoimmune phenomenon against thyrocytes. Why autoimmune mechanism become active against thyrocytes, we do not understand fully. But in most cases, it is the silent process, and mostly it is Hashimoto thyroiditis. There are other types of thyroiditis also which can cause hypothyroidism. Iodine deficiency is believed to be the commonest cause of hypothyroidism in our country, but this statement does not have any evidence. Iodine deficiency typically will cause goiter, and most such goiters are euthyroid. So iodine deficiency as a cause of hypothyroidism without goiter, I'm not sure whether that is a common condition or not, but it is reported as one of the conditions which can cause hypothyroidism. Enzymatic defects in some families, there is hypothyroidism, and some enzyme which is required for the synthesis of thyroxine that may be absent, and that could result in hypothyroidism, and that hypothyroidism will run in the family and multiple members will be affected. Of course, if there is thyroidectomy, if, for example, somebody had cancer of the thyroid and he was operated for thyroidectomy, and that could cause hypothyroidism. Normally, after thyroidectomy, we put the patient thyroxine, but if somebody fails to take that thyroxine, that could cause hypothyroidism. Then a radioactive iodine thyroid ablation. This is done for hyperthyroidism. And again, after radioactive iodine thyroid ablation, we put the patient on thyroxine. If somebody is not put on the thyroxine, he could or she could develop hypothyroidism. Radiation to the neck for some other reason. There was some lymphoma of the neck. Radiation was given to that destroyed thyroid gland. Some drugs can have anti-thyroid drugs, and agenesis. Congenitally, sometimes thyroid gland does not develop. Out of these, I think most is idiopathic or autoimmune. We actually need not find the cause, because ultimately the cause is not treatable, the cause is not reversible. In all cases, we have to replace with thyroxine. So I think we have to give replacement therapy for life. So it doesn't really matter what has caused hypothyroidism. But for examination purposes, you need to know these causes. Of all, I think iodine deficiency and autoimmune, these two you should remember. So in every slide, I will give you the whole list, and then I will pop up one which is like a take-home message. So out of all the possible causes, if you remember these two, iodine deficiency and autoimmune thyroiditis, I think that would suffice. Talking about the pathogenesis of this disease, it is autoimmune, and first is the formation of antibodies. These are thyroid peroxidase antibodies, which are present in majority of the cases of hypothyroidism, indicating that majority are due to autoimmune destruction. So when antibodies are formed, these are actually indicator of autoimmune phenomenon. Actual the cause of damage is perhaps activated lymphocyte, T lymphocyte, but TPO antibodies, they serve as a sign of autoimmune phenomenon. And for a long time, there is autoimmune destruction of the thyrocytes. There is active autoimmunity, but patient remains euthyroid, because like all organs, we have a lot of reserve in the thyroid tissue also. And slowly progressive thyrocyte damage occurs, and before one develops frank hypothyroidism, a clinical condition called subclinical hypothyroidism develops. This is actually a biochemical abnormality. Patient may not have any symptoms at this stage. We will discuss about this lately, but this is like a preclinical condition. And ultimately, there would be almost complete damage to the thyrocyte tissue, and thyroxine will be deficient, and patient will develop frank hypothyroidism, which progresses to myxedema, which is actually extreme form of hypothyroidism. Symptoms: fatigue loss of energy and lethargy. I told you earlier that this is truly a multi-systemic disease, and practically every cell, every organ, every part of body is affected. So you would have multiple symptoms. I'll go through all those symptoms just to give you an idea, but then I will focus on two or three key symptoms. So fatigue, loss of energy, and lethargy. And these are, non-specific symptoms. There are many other diseases where you can have these symptoms, including depression. Weight gain, again, there are other causes of weight gain in hypothyroidism because there is deposition of myxomatous tissue in the subcutaneous tissue, so that causes weight gain. And there is cold intolerance. This is often narrated in the books as one of the symptoms of hypothyroidism. But in our country, the temperatures is so high that this is not a very predominant symptom. Dry skin, yes, there is a very typical look of the skin, and it is dry and thick, and one can easily identify. And hair loss, especially the scalp hair loss and the body hair loss, and hair also become very coarse. Then sleepiness, yes, because thyroxine is a stimulant, so patient with hypothyroidism may feel drowsy or sleepy or somnolent during the day. And muscle pain, joint pain, weakness in the extremities. This is again common. And I've seen that these patients actually have some kind of inflammation in the muscle because many patients with hypothyroidism would have massively elevated CPK that indicates muscle injury. So muscle pain and body pain is another common symptom. Depression, hypothyroidism can come in the differential diagnosis of depression, but hypothyroidism itself can cause depression. I've seen people with frank hypothyroidism ending up in mental hospital. And emotional lability, mental impairment, and forgetfulness, impaired memory, inability to concentrate, these are all indicating of slow mental function. Constipation, yes, that is another symptom, very non-specific though, but this is one of the symptoms. And menstrual disturbances, there may be impaired fertility also. In menstrual disturbances in hypothyroidism, there is usually a tendency toward hypermenorrhea or polymenorrhea, not or menorrhagia, not the deficiency or hypomenorrhea. There may be decreased perspiration and paresthesia's nerve entrapment syndrome. Why so? Because when patient gains weight, it can sometimes presses upon the extra tissue can press upon some nerves like median nerve, the ulnar nerve, and there could be entrapment syndromes because of the deposition of myxomatous tissue. Then blurred vision because of eye involvement, and decreased hearing. This is another common symptom because of the same problem, deposition of abnormal tissue in the ossicles, I think, and the fullness in the throat, hoarseness. So these are so many symptoms. So I think out of these, if I have to come up with the key symptom, I would say if there is weight gain, which is unexplained, patient says that his or her intake of food has been the same as usual, but patient has gained weight, and there is a lethargy, general weakness, and of course in the examination we'll find out the cardinal signs. Somebody complaining of unexplained lethargy and weight gain in the background of these symptoms, I think you should suspect hypothyroidism. Generally, the suspicion of hypothyroidism should be high because it's a common condition and easily treatable. So there's no harm in having the test even if there is with a slight suspicion. Signs, again, many signs. Weight gain is actually the symptom, but weight gain could be a sign also if you maintain patient's record and you notice that patient has gained weight. That could alert you for a possible hypothyroidism. And then slowed speech and movement. Patient with hypothyroidism have characteristic speech. An experienced person can easily identify. It's a very slow. They talk syllable by syllable, and because of the slow movement of the speech muscles and thickness of the tongue, their speech has got a characteristic uh, style. There may be dry skin and there may be pallor. Pallor could be due to anemia, and anemia is part of hypothyroidism, but even without anemia, patient may look pale because skin is thickened. Reduced and coarse and brittle hair, and dull facial expression. And you can understand why what I mean by dull. Their communication, they are not very alert, they react slowly, and overall expressions are dull. And coarse facial features, and remember, coarse facial feature may be a common normal phenomenon, because some people, they have coarse facial features. So this should not actually be the cardinal sign of hypothyroidism. Periorbital puffiness. Again, there are other causes, but one of the causes is hypothyroidism. Then macroglossia. If you ask a patient to protrude his or her tongue, you will notice that the tongue is big in size. And then goiter, simple or nodular. Uh, in majority of the patient with hypothyroidism, you should not expect a big goiter. But in some cases, especially those who have chronic iodine deficiency, you could have a big nodular thyroid, and those who have Hashimoto thyroiditis, you could have a small but firm gland. So there could be small goiter, but there are many people, I think majority, they have hypothyroidism, but they do not have visibly enlarged thyroid gland, so they don't have goiter. Hoarseness of speech during history taking. When you talk to them, you notice that their speech is hoarse. Of course, if somebody has hoarse speech, you need to ask if this change has been recent or not. There are some people who have naturally their speech, their voice is hoarse. So you need to ask them if it has been a relatively recent change. Then bradycardia, pulse rate may be low, but usually in 60s. And blood pressure may also change. Systolic blood pressure may be less than the normal, and diastolic blood pressure may be high. So these patients tend to develop diastolic hypertension. There could be pericardial effusion, and of course, it may not be easy to pick up pericardial effusion clinically, but that is one of the signs. And abdominal distension and ascites could also be present. These are signs of extreme hypothyroidism. Hypothermia in severe cases. Again, in our country, because most of the year the temperatures is very high, so our people do not develop hypothermia very often. But of course, if somebody has hypothyroidism and is stuck in a place where there is no air conditioning and the temperature is low, then he could have hypothermia also. Non-pitting edema, and this is a very important finding. People have this edema and it is either non-pitting, and you know what I mean by pitting or non-pitting. When you press against the malleolus, and after a few seconds you notice a pit in if there is a pitting edema. But in these patients you see that there is edema, but when you press there is no pitting, and or there may be very mild and very slow pitting in some cases. And this will be seen in patient with mixed edema. And pitting edema of lower extremities. Now this is also possible because of the secondary involvement. I just mentioned that patient with hypothyroidism could have pericardial effusion. So if they have pericardial effusion, they may develop right heart failure. That could result in pitting edema of lower extremities. But mostly the edema of the hypothyroidism itself is non-pitting type. Hyporeflexia with delayed relaxation. This is extremely important. Now, if you know what I mean by hyporeflexia and delayed relaxation, I think just seeing this reflex make the diagnosis almost definite. Although we know that hyporeflexia and delayed relaxation may not be present in mild cases, but if it is present, it is so characteristic that you already made the diagnosis of hypothyroidism. So out of so many signs, and if I have to pick up the most important, dry, rough skin, experienced person will immediately recognize this skin, and non-pitting edema, almost on the whole body, but especially you will note on the lower extremities, you see that there is edema, but it is non-pitting or pitting very slowly. And then slow, deep tendon reflexes. All deep tendon reflexes will be slow, but typically we do the ankle jerk for this purpose. And I have a video of this from my own patient. I'll show you this. So these are the signs. General physical examination you can see, and let me see if you can describe your findings. All of you note that this patient has a dull facies. You also note that there is edema, and you also note that there is macroglossia. Patient is unable to close mouth, and those of you who are very observant will also note that the hair are coarse. And so these are, I think, an experienced person will immediately diagnose hypothyroidism or mixed edema just by looking at the face of the patient. Similarly, these are the characteristic skin changes. Now, I'm going to show you this deep tendon reflex, which is slow in relaxation, and this is called Woltman sign. I'll just play this video. You please concentrate, especially during the relaxation phase. When hammer is pressed, muscle will contract, but then it will relax, and just notice the relaxation phase is slow. Okay, that was it. And now let's discuss, we have talked about symptoms and signs, and after symptoms and signs we go for a laboratory test, and that is these are some specific laboratory abnormalities. If present, they will confirm the diagnosis of hypothyroidism. But since it is a multisystemic disorder, and it is likely to produce many other abnormalities in the body which are non-specific, which can be seen in other conditions also, but they will be seen in hypothyroidism also. Now, among specific one, first of all, TSH. TSH is the most sensitive test and is the first one to become abnormal. And if your suspicion is not very strong, you just want to rule out hypothyroidism, you just may have TSH and you expect it to be high. And in primary hypothyroidism, TSH will be high in primary hypothyroidism when the disease is in the thyroid gland itself. And I have already mentioned that in 90 to 95% of the cases of hypothyroidism, disease will be in the thyroid gland, so it will be primary hypothyroidism. And if you happen to see a rare case of secondary hypothyroidism, then TSH will be low. Another abnormality is T4, thyroxine. You could have, when we order thyroxine, usually laboratories will do total thyroxine. Like other hormones, thyroxine is protein bound. So nowadays we have free thyroxine available also, and free thyroxine of course is a better indicator of thyroid status. So I think you should order free thyroxine, which is abbreviated as free T4. So in hypothyroidism you expect free T4 to be low. T3 is not necessary. T3 is usually included when we order the test, but T3 could be normal, or maybe it's not necessary actually. TSH and T4 are sufficient to make a diagnosis. Anti-TPO antibody is again not very essential to make the diagnosis of hypothyroidism, but will really be helpful to substantiate the diagnosis. And I think one role of anti-TPO is when patient has borderline values, when patient has subclinical hypothyroidism, presence of anti-TPO would mean that this patient is going to progress to frank hypothyroidism, so treatment may be started early. Anti-TG antibodies, I don't do them in routine, but they may also be present because both of them, they indicate autoimmune phenomenon. And radioactive iodine uptake. Now this is not done as a routine these days. But previously this test was done. What is this test? This is patient is given radioactive iodine, and the radioactive iodine, like normal iodine, will be concentrated in the thyroid gland. And if you take the image of the thyroid gland, it will show how big or how small the thyroid gland is, and if the uptake of iodine is uniform or is non-uniform. So radioactive iodine in hypothyroidism, you expect thyroid gland to be slightly enlarged, and you expect radioactive iodine uptake to be reduced if you do this test, but it is not done as a routine. Now, some non-specific manifestation, many patients with hypothyroidism would have associated dyslipidemia or hyperlipidemia, and many patients also have normochromic normocytic anemia. Some have macrocytic anemia also. So these are associated abnormalities, and there could be hyponatremia because these patients are slightly volume overloaded and they may have mild hyponatremia. And CPK, I have seen patient may have very, very high CPK. I've seen people having CPK 10 times upper normal. So a youngster would suspect some kind of myopathy or myositis or muscular dystrophy on high CPK. If patient has features of hypothyroidism, don't worry about high CPK. This is going to settle down once you treat these patients, and this explains the muscle weakness. Creatinine, serum creatinine in the kidneys may be otherwise perfectly normal, but because of hemodynamic changes, creatinine is expected to be borderline high. Now, these non-specific abnormalities may not require any treatment straight away. Although if somebody has frank dyslipidemia, anemia, you could start the treatment of these two. But one approach is you focus on the hypothyroid state, and once that is treated, and then to revisit these problems, and if they require any medication, then you can add some more medicines. So out of this long list of laboratory abnormalities, the cardinal laboratory abnormality is elevated TSH in primary hypothyroidism and reduced FT4 in all cases of hypothyroidism. So if you want to do simple test for the diagnosis of hypothyroidism, you could do TSH and free T4. And if you have just very mild suspicion, just do TSH. TSH and FT4 both will give you a very, very accurate and reliable diagnosis. Differential diagnosis, since it is a multisystemic disease with multiple symptoms, multiple signs, so differential diagnosis will be long. Anemia, Addison disease, chronic fatigue syndrome, obesity, depression, nephrotic syndrome, obstructive sleep apnea, and fibromyalgia. And trust me, this is not the complete list. Patient with hypothyroidism can mimic with many conditions. So you need to be vigilant to identify hypothyroidism. The commonest differential diagnosis in my experience is simple obesity. There are many women, also men, who are overweight and they're worried about their weight, and somebody suggests to them, have your thyroid function test, and they have their thyroid function test and their TSH may be only marginally elevated, and they come excited to me and asking that they have found a problem and they have found the cause of their being overweight. And then I tell them, no, this is not the cause. Obesity is separate issue, and your thyroid values, they do not explain obesity. So obesity is extremely prevalent all over the world. So that would be the commonest differential diagnosis of hypothyroidism. Now, I explained to you that the TSH is very, very sensitive and becomes abnormal first of all. And with this picture, I'm going to explain how this happened. There's something called a reciprocal relationship. And if there is a reciprocal relationship between two things, like for example, A and B, now if A goes down, B goes up. And if A goes up, B goes down by the same proportion because the fulcrum, the pivot is in the center. Now just see with this animation, this is like A goes down and B goes up. And if B goes down, A So this is the reciprocal relationship, but by both they become abnormal by the same degree. But when it comes to uh, free T4 and TSH, they also have a reciprocal relationship. But in this case, this pivot point, the central point, the fulcrum is on one side, the TSH arm is much longer as compared to FT4 arm. And this is just like seesaw you must have experienced in your childhood. So in this case, you see if there is a reduction in FT4, only modest reduction in FT4 would lead to marked elevation in TSH. So there may be a situation where there is reduction in FT4, but FT4 free thyroxine is still within normal range, but FT4 would have gone much higher than normal. So that is why TSH is the most sensitive test. It is the first to become abnormal and last to become normal once you give them treatment. Okay, so FT4 is very useful, very sensitive test for patient with hypothyroidism, primary hypothyroidism. Because when we start treating them, we have to repeat their thyroid function test many times. So that will add to the cost. So you could go for just TSH, and once patient is, in your opinion, euthyroid, then maybe you can have again complete thyroid profile just to satisfy the patient that now everything is in control. Now, diagnostic and management algorithm. I'll just go through this algorithm and see how we work to make a diagnosis and how we treat these patients. Now, first of all, as I just explained, our first line of investigation should be a TSH and FT4. After, of course, we have clinically suspected, we go for TSH and T4. And then there are three possibilities. One possibility is, then I will give you a few seconds to think about this. There is TSH is high and free T4 is low. Guess, where is the disease? FT4 has to be low because this is a case of hypothyroidism, but TSH is high. And you remember that TSH is high in primary hypothyroidism. You're right. So primary hypothyroidism will be diagnosis in majority of the cases. If it turns out to be primary hypothyroidism and you know that this is already a chronic condition, then you would start the treatment, and the only treatment required in these patients is thyroxine. Thyroxine is available and incredibly cheap, and I'll show you how to use thyroxine. So according to this algorithm, if patient has high TSH and low FT4, the diagnosis is primary hypothyroidism and the treatment is thyroxine replacement. And this is for life. Now, second condition, again, I will give you a few seconds to think. TSH is low, but FT4 is also low. FT4 is low, of course, it was expected to be low because it is hypothyroidism, but TSH is also low or lower normal range. What do you guess? I think you have figured out correctly. It is secondary hypothyroidism. Thyroid itself is normal, but it is not functioning properly. It is not producing enough thyroxine because it is not getting enough signal from the pituitary through TSH. Remember, TSH is sometime within normal limit in the lower normal range, not necessarily lower than normal. What I say is that if you have clinical picture of hypothyroidism and even TSH in normal, you just what you see is if TSH is elevated or not. If TSH is not elevated, if it is within the normal range or less than normal, then diagnosis of secondary hypothyroidism is very likely. Now, in this case, what do you think? How will the treatment differ? In secondary hypothyroidism, does it matter if it is primary hypothyroidism or secondary hypothyroidism? As long as it is hypothyroidism, the treatment would be same. No? Those who agree with me, no? Yes, they are right. In this case, actually, there is very likely that this patient has deficiency of other hormone also. In this case, it is very likely that patient has deficiency of there is ACTH is also deficient and cortisol is also deficient. In these patients, it is important to start with the steroid first and then put them on thyroxine. And I explained in one of the lectures that if you give them thyroxine straight away, they could actually end up in a Addisonian crisis. Okay. Now the third situation is very tricky situation. TSH is above normal. You know, in most of the assays, TSH upper normal is 4. And but it is less than 10. So it is high, but not frankly high. And free T4 is normal. So as far as free T4 is concerned, there is no hypothyroidism, but TSH is elevated. So what do you guess? Give you a second. So this is actually a case of subclinical hypothyroidism. Now, this is a condition where the approach is different. I will have some slides on this. I think best approach, in my opinion, in these cases would be wait and see, or sometimes treatment is given. I'll discuss in one of the slides. This is actually observe and or treat. We have to decide. Okay. Now, we have made the diagnosis of hypothyroidism, let's say primary hypothyroidism, then we have to treat them with thyroxine. Thyroxine replacement therapy, TRT. First of all, I'll talk about the standard approach, and then I will talk about the approach in young people and approach in elderly people. So the standard approach is you start with thyroxine. The commonest preparation of thyroxine is 50 mcg, and you could start with 50 mcg or you could start with 100 mcg. I think it is best to start with 50 mcg, and after every 2 weeks you increase it by 50 mcg. To save patient visit, what I do is I ask my patient to start with 1 tablet and ask him or her to increase it to 2 after 2 weeks without going for the test. And then I ask them for after another 2 weeks go for 3 tablets and then continue it for 6 weeks. So that is the time, or 6 to 8 weeks, and I call them back after 8 weeks and I ask them to bring their fresh TSH. Now, if patient has already become euthyroid, and 3 tablets is usually sufficient dose for most patients, 2 to 3 tablets is usually the dose. So 3 tablets, which is equivalent to 150 microgram, if patient is euthyroid, that would mean his or her TSH will already be normalized. But if TSH is not normal, you accordingly adjust the thyroxine dose. If TSH is still high, you further increase the dose of thyroxine. If TSH has gone below normal range, then you reduce the dose of thyroxine. And then you again repeat the test after 8 weeks. Please note down, we will reassess not earlier than 8 weeks because TSH is a protein and has got long life. Even if patient becomes euthyroid in 2 or 3 weeks, his or her TSH will take about 8 weeks to come to normal range. So I think there is no hurry. It's a lifelong condition, and I think doing TSH after 8 weeks is appropriate. Doing it earlier might actually be unnecessary and will certainly be sometimes confusing. So 8 weeks you keep doing this until you have your TSH normal and FT4 is also within normal limits. And it is required that on 2 consecutive 8 weekly visits, if somebody's TSH and free T4 are within the normal range, then he or she can be declared euthyroid, and the same dose has to be continued for life. This is important. You need to explain to the patient that this treatment has to be continued for life. Now, this is a place if you have not given treatment for those associated conditions, dyslipidemia, anemia, and if you have not given treatment earlier, I think that this is the time that you have those tests again. If patient still has those conditions, then you add therapies for those conditions. Many would have their abnormalities corrected by just thyroxine replacement. Remember, thyroxine is for life with periodic increments. Now, this is thyroxine replacement in young people. Uh, this disease can occur in young people also. Why we go slow in standard treatment? Because people may have underlying heart disease, and pushing with the thyroxine too fast may actually precipitate ischemic heart disease. So in young people, since ischemic heart disease or atherosclerosis is very unlikely, uh, so we may start with estimated full dose. Now, depending upon body size, if somebody is 75 kg, my guess would be 100 mcg. If somebody is around 100 kg, my guess would be 150 mcg. So we can start with the estimated full dose and continue with it. And of course, you have to go through with the same process, 8 weekly TSH, and then you adjust the dosage. So this is in young people. Those who are not very young, like myself, patient may have coronary artery disease already known, or they may not have symptoms of coronary artery disease, but they may have underlying coronary artery disease. And remember, this is particularly likely because patients with hypothyroidism may have dyslipidemia also. Okay, so when there is ischemic heart disease or ischemic heart disease is likely or cannot be ruled out, you have the policy of start low and go slow. This is very important in elderly, frail, and those with ischemic heart disease. You start with 25 mcg, and instead of every 2 weeks, you may make the increment after 4 weeks, like increase by 25 mcg every 2 weeks, 3 weeks, 4 weeks, and then make the dose adjustment. So I think you remember, start low with just 25 mcg and go slow. Some would suggest even smaller than 25 mcg, like 12.5 mcg. Ultimate aim would be to make them euthyroid. There are some general principles of thyroxine replacement. Once daily, it does not have to be given 2 or 3 times a day. It is given once daily on empty stomach. And what is the best time? I think mostly best time is in the morning. And in our culture, people wake up for morning prayer. I tell my patient that when you wake up for your morning prayer, that is the time you take this tablet with 1 glass of water on empty stomach, and you take your breakfast or other stuff 2 hours later. So at least 1 hour empty stomach with glass of water. And it has to be continued for life. Monitor TSH once a year or as appropriate. Now, those who treat diabetes, they know that on every visit we have to monitor their A1C and their sugar, because things do not remain stable in diabetes. But in hypothyroidism, thyroxine is a very reliable drug, and once somebody has developed complete destruction of the thyroid gland, so patient is likely to remain stable on the given treatment. So you could do TSH maybe once a year or whenever you suspect. Every time the patient visits you, you must ask if the patient is taking medicine. If patient has stopped taking medicine, then there is no point in doing the TSH. Then you simply ask the patient to restart where he left. Make adjustments as necessary. A patient undergoes some operation, or if there's a trauma, pregnancy, you need to make some adjustments. Now, what is euthyroid dose? Of course, you would guess that euthyroid dose is when your T4 is within normal range. Suppose this arrow gives you the upper and the lower limit of the normal range. So TSH should be within and T4 should be within normal range. Euthyroid. But if you want to go for perfection, then in young people, the approach is that you bring their TSH to the normal range, but in the lower half of the normal range. And you push their T4 to the upper half of the normal range. So both are within the normal range, but free T4 is within the upper half of the normal range and TSH is in the lower half of the normal range. That means you have to keep them slightly physiological hyperthyroid. So this is the philosophy. This has a better prognosis. Now, when it comes to elderly, then the approach is slightly different. Because of possibility of underlying coronary artery disease, we don't want to produce hyperthyroid state. So in this case, the approach is slightly different. TSH is kept in the upper half of the normal range, and FT4 is in the lower half of the normal range. Sometimes you will not be able to do this despite your intentions, but this should be actually the approach. Hypothyroidism during pregnancy, since it is a common condition, this affects young people, young women also. So it is a good, there's a good possibility that you see a case of hypothyroidism with pregnancy. So if patient is already a known case, ideally patient should consult the physician and pregnancy should be planned. If patient just turns up with this news that she is now expecting, I think one simple approach is that you add 2 doses per week. Somebody is taking 75 microgram every day and is euthyroid, you can add 275 microgram doses 2 times a week, like maybe on Saturday and Sunday, whatever 2 days. So simply add 2 doses on which patient was already. Or if it is a new case, or if you want to go by trimester specific TSH levels, if you have the facility of going for perfection, then these are the TSH level. For first trimester, TSH should be less than 2.5. In second trimester, TSH should be less than 3, and in the third trimester, it should be less than 3.5 to maintain absolute euthyroid state. In pregnancy, it is particularly important to maintain euthyroid state to ensure that the pregnancy is successful and baby is normal. And be assured, and you also tell your patient that it is absolutely safe. Thyroxine is category A. Thyroxine which we take in the form of tablet is the same thyroxine which our body makes. So it has got no known teratogenic effect. And conceiving and having pregnancy with hypothyroidism carries much more risk than having thyroxine, becoming euthyroid and having a successful pregnancy. Now the approach in secondary hypothyroidism is slightly different, and in this case we first have to replace corticosteroids with prednisolone that is available in our country, and the usual dose is 15 milligram. That is like 3 tablets, 2 tablets in the morning and 1 in the afternoon. And you can also start with the thyroxine 2 weeks after starting corticosteroid, and approximately 100 to 125 mcg. That is the dose. Now you make sure that then you make final adjustment with T4 and TSH and other tests. So these are the starting doses, and then you can make final adjustments. Refractory cases. Now this is important. If somebody is taking thyroxine and his condition is not improving, his lab is not improving, first of all, one established principle is that you check the adherence. I have used the word compliance, but these days we use the word adherence, whether or not patient is taking treatment. So ask every possible question, ask the family, check the drug supply, check the prescription, a patient is actually taking the medicine. So the commonest cause of refractoriness would be that patient is not taking medicine. The problem with the medicine is that they work only when you take them. Then there could be absorption problem. Patient may have some kind of gastritis, or patient may have malabsorption disease. This would be indicated by the GIT symptoms. There could be drug-drug interaction, and that is why it is emphasized that thyroxine should be given at the time when patient has got empty stomach. It should not be given with any other drug. So I think make sure that patient is taking thyroxine that way. Then TSH polymorphism. This means that sometimes patient may have enough thyroxine, but because of some abnormality in the TSH receptors or TSH itself, and then TSH might stay high. So then we rely on T4. Deiodinase deficiency. This means patient has got, because I told you that in the peripheral part of the body, T4 is converted into T3, and T3 is metabolically more active. If somebody has deiodinase deficiency, he may have normal T4, but T3 may still be low, and patient may still have symptoms of hypothyroidism. So in these cases, you have to give some extra thyroxine. Then there's some other conditions also where there could be refractory cases. So I think these should be left for the specialist. Now, prognosis, I used to say the prognosis in hypothyroidism is excellent, but I say now it is very good, but maybe slightly short of excellent. Now, excellent would be like if you become normal. Patient with hypothyroidism on thyroxine is close to normal, but not exactly normal. This is how I explain. A normal person, suppose this is the range, upper and the low range, and our thyroxine varies the level varies in the different times of the day, different level of physical mental activity, but the level of thyroxine is just right for that given condition, but for that given situation. But if we give thyroxine, then we produce a like flat level. So if you have a flat level, then at this point thyroxine is normal, but it is less than what should have been in a physiological state. So you are practically slightly hypothyroid here. In this situation, you have thyroxine in the body, which is normal, but it is slightly more than what should have been in a normal physiological state. So you are slightly hyperthyroid. So this may be little more perfection, but some people, they have this problem. So patient with hypothyroidism may still continue to have some symptoms. So the prognosis is very, very good, but maybe slightly short of excellent. Make simple and practical regimens. Now we have multiple strengths available. I think previously we just had 50 mcg and we used to give one tablet daily or two tablets daily, or sometime two tablets and three tablets on alternate day. But now we have multiple strengths. We have 25 mcg, 50 mcg, 75 mcg, 100 mcg and 125 mcg. Most patients will need just one or two pills. So after titration, if patient's dose is, for example, 125 mcg, just ask a patient to continue with one tablet of 125 mcg. Reducing number of pills is actually like improving compliance. Side effect of thyroxine, practically none, and the side effects will occur only if you give it an overdosage. So that is actually the iatrogenic problem. If you give in the right dose, patient should not have any side effects. In some cases, if it is overdose, patient may develop osteoporosis. And again, in overdose patient, you may develop exacerbation of ischemic heart disease and heart failure. And of course, we do not want these conditions because we monitor the patient and keep their thyroxine level within the normal range. Some additional abnormalities, dyslipidemia, hypertension, anemia. I told you most of these conditions will revert back to normal with thyroxine replacement itself. But at the end of first initial titration phase, a patient still has this dyslipidemia, separate treatment for dyslipidemia and hypertension, and anemia can be given. And these are, of course, separate topics, and we will cover them in separate lectures. So there's conditions called subclinical hypothyroidism, and these days we see quite a few patients of subclinical hypothyroidism. Even students need to know this condition. Now let me just briefly give you an account of subclinical hypothyroidism. When FT4 is normal, free thyroxine is within the normal range, and TSH is slightly high, more than upper normal. Some assays say upper normal is 4, some say upper is 5, but from upper normal to less than 10. If that is the case, we call it subclinical hypothyroidism. Now, as the name says, it is subclinical, you may not have any symptoms. Now, these patients are asymptomatic and no treatment is required, but you don't want to miss the possible hypothyroidism in the making, so you follow them up. That is the best approach, but treatment may be given, thyroxine may be started in some cases. And what are those cases? Opinion varies. I think most patients, they immediately, though many physicians, they immediately start with thyroxine. I tend to hold my temptation of starting thyroxine till I'm sure that this is actually hypothyroidism, not just a subclinical hypothyroidism. Some people with subclinical hypothyroidism will revert back to euthyroidism. Some will stay subclinical hypothyroid for their remaining life, and only few will develop hypothyroidism. And thyroxine may be given if patient is symptomatic. If patient is having symptoms of hypothyroidism, then even with borderline value, it is recommended to treat them because they have symptoms. And if they have hyperlipidemia, because then they are likely to develop ischemic heart disease. And if anti-TPO is positive. Now this, in my opinion, is the most important indicator, because anti-TPO antibodies would not be present in normal healthy person. If anti-TPO antibodies are present, although patient is in subclinical state, but this indicates that the damage would be progressive, and might as well start treatment right away rather than waiting. Then if there is a goiter, small goiter, I think that would also be an indication, because with thyroxine, goiter probably will stop growing further. So summary points. This was a long lecture, but I have to cover the complete topic. And summary points. First, TSH and free T4 are the best tests for the diagnosis and monitoring. Subclinical hypothyroidism, wait and see until patient develops symptoms, or if one of those conditions I mentioned, especially anti-TPO antibodies are present, then you start treatment. Then different TSH levels and thyroxine dosage in pregnancy, and then low dose and slow escalation in elderly and those with underlying ischemic heart disease. There is no hurry. Take time, take 3 months, 4 months, 6 months to make them euthyroid. And lifelong therapy adjustment is needed in some situations, like pregnancy, like trauma, like surgery, things like that. And with that, I like to conclude my talk, and with this statement that hypothyroidism is one of the most treatable diseases. It is very common. It can affect any body system. It can cause mental disease. It can cause any problem, and it is treatable, and it is one of the most treatable conditions. Thank you very much for watching this video. I really look forward to see you in my next presentation, next video, which will be on hyperthyroidism. Thank you very much.